Welcome back to the tutorials. With this session, we're now going to focus on CNA Value Statement number 3, which looks at the notion about promoting and respecting informed decision making. So the focus for this tutorial will be to look at, obviously, the value statement number 3, but also exploring such terms that are associated with this, such as self-determination, autonomy, choice, and informed consent. And we'll also spend some time talking about the recent developments with regards to medical assistance in dying and the role of nurses within this particular option, as well as some of the ethics associated with this. This code of ethics focuses on the fact that we as nurses recognize, respect, and promote a person's right to be informed and to make decisions. But we are also extremely sensitive to the inherent power differentials between ourselves and other care providers and those persons that are receiving our care, and that we don't misuse the power to influence that decision making. So we'll be drawing upon some of the discussions that we actually had in the previous tutorial with regards to patient education and the issues about information that's provided and how this actually supports informed decision making. So we have to have some discussion about, why is it that we really need to understand autonomy? And when you talk about autonomy with regards to informed decision making, there's a variety of perspectives and different layers about this. We do need to recognize when autonomy is an issue, when individuals do have the ability to make autonomous decisions, or what are other factors that may influence that. To what degree do we decide what is autonomy is a reasonable goal? So how much are we actually advocating and supporting for autonomy within patients and their decision making? But at the same time, also understanding that there are limits to autonomy and when those limits are actually reached and under what circumstances. So some of the provocative questions that I think we need to have a think about as nurses, as we start to look at the notions about autonomy and informed consent and things of that nature, throughout even looking at your own practice now in terms of practicum, have you wondered about your patient's ability to give consent? We have the notion about very formal consent, but what about all the implied consent? How do we ask for permission or consent for their care? How often do we simply enter into a patient's room and let's say your typical post-op patient and say, okay, it's time to get up and go for a walk, or it's time to get up and get out of the chair? Do we actually allow them to refuse? Are we actually getting their consent? Have we had situations where you've actually had to help someone decide, make a decision, and or give consent? And what are some of the situations where we really truly engage with patients about the discussion about consent, or are we just simply assuming and actually coercing to some degree sometimes unintentionally them to give us consent? How is it that we really help someone to make the best possible decision? And what does the best possible decision mean? Based on whose lens? Our lens? Their lens? What do we consider to be the best possible decision? And how do we know that based on looking at the whole person and all their circumstances, what is that best possible decision? And who really decides what's best? What perhaps have you noticed already in practice, particularly with regards to nursing care in terms of what makes things the most possible decision and the best possible decision at that particular point in time? So I ask you to perhaps just pause here at this particular slide and have a think about these questions and what are some of the scenarios that you've seen arise within your practicum setting and some of the interactions you may have had with your patients, as well as observations of interactions with other care providers and patients. So as we think about it, also, how does this apply to us and our own autonomy? And what kinds of limits are there on our autonomy? As nurses, we are self-regulated autonomous professionals, but there are limits to our autonomy. There are limits with regards to legislative limits, regulatory limits, and even within organizations in terms of what are the bounds of nursing practice that could be placed really based on the organization with when you work. And also think about the limits of your own autonomy as novice practitioners, as students, and how that autonomy actually grows or becomes influenced even by the degree of your own experience and competency in terms of nursing practice. So some of the things to consider are the concepts of informed decision making and the right to choose really ever straightforward, even in the case of a competent adult. Can a child make decisions and provide consent? And we'll talk about this a little bit later on in the presentation. And also think about within your readings, specifically the case study about Mary. So the pregnant woman that had severe depression, for whom electronic convulsive therapy was recommended. So she has to decide for herself, but also take into consideration the impact this actually has on her unborn child. So all these various layers, and we don't really look at the notion about consent and the notion about informed decision making really being ever straightforward. There are so many factors that can come into play to influence this. So if we look at from the philosophers' contributions with regards to, again, how they view individuals, with Immanuel Kant, again, it was that categorical imperative that we really need to make sure that we are treating people as an end and never as a means to the end. So always looking at how do we really take into consideration of the individual. What are some of the routines that we sometimes impose on patients? And how is it that, again, we really need to look at them as the end and not the means through which we achieve things? That the notion that people must always be treated with respect and dignity, and that people have an inherent ability to reason, and that we should not assume a paternalistic approach. And this goes back to the original statement that recognizes the inherent power differentials, and we have to look at as healthcare providers that we don't misuse that power in order to really obtain consent from individuals. Whereas Mill's idea was really more so about the notion about liberty, recognizing that we can make decisions on ourselves, but only in so much as they don't affect the welfare of the others. So again, looking at the notion about the greatest good for the greatest number. That our autonomy and the ability to freely choose cannot have a negative influence on others. So hence our decisions are limited by the effects that they can have on others, and that others are allowed, if you will, to decide, but really only if they have the capacity to do so. And so you can start to see some of these elements coming forward, again, as we start to think about the various aspects with regards to consent, informed consent, capacity, and so on. The feminist ethics, I think, really contributes to the notion about relational autonomy, but also takes into consideration the notion of social justice and the notion of equities. So it really calls upon us to think more than just an individual's right to make a decision, but it's about how people live and whom they consider when they're making decisions. We'll come back to talk about Aziza's story, which was the case study as part of your readings today, and recognizing all the different elements that come into play when people are making decisions, including culture. But we'll come back to that a little bit later. And I think this is a specific element from your readings in today when they talk about in practice we see how autonomy is lived in relationship to others. And again, I'll call your attention to Aziza's story. Lived autonomy is found in personal connection to others and the responsibilities. So again, we cannot separate this from decision making in terms of the notion about relational autonomy, but that is autonomy in respect to our relations to others. And that recognizing that sometimes people need supports in making decisions. The different influences in terms of on bioethics is recognizing when we come back to the core bioethics as a specific ethical theory or ethical framework, as you may recall, that autonomy is really at the core of bioethics. But recognizing the notion about choice and autonomy along with, and how does that look at the notions about beneficence, non-maleficence, and the notion about social justice. But also recognizing, how the law is really highly influential in the way we act out ideas of autonomy. So bringing back some of our conversations with regards to the content on ethics and the law, and where, again, there may be laws that can influence or limit the autonomy of others in relationship to the better good. We'll have some discussions later on with regards to medical assistance in dying, but we will tell you that the notion about medical assistance in dying in terms of that new legislation that just came into effect in June 2016 was really born from the desire of the general public and patients at large for greater autonomy, the right to choose how they wish to have in terms of their end-of-life care. So we'll get it back into that conversation a little bit later, but that, again, looking at how laws were changed as a result of the increased desire for autonomous decision-making about the most important decision probably someone could ever make in their entire lives. So this diagram is just intended to look at the notion about all the different areas that really influence around the concept of autonomy, not precluding the notion about the legal system, but all the various ethical theories that we've spoken about so far really do look at, in one way or another, the notion of autonomy. And this decision-making model, in terms of looking at what are the various factors that really influence decision, we're going to touch upon all of these as we go through the rest of the presentation here. But really looking at the notion about autonomy and relational autonomy that we just spoke about, the notion about consent, the virtues that are actually involved when talking about informed decision-making, the notion of honesty, truth, and again, recognizing the notion about power and those power differentials. The role of substitute decision makers when the individual does not have that capacity for one reason or another to make their own decision. What are the roles of substitute decision makers, and how does that come into play? The notion of assent and dissent in terms of autonomous decision making. And again, as we just talked about, the ability to make my own decision, so voluntary informed decisions with regards to the notion of capacity and comprehension. So we really want to look at all of these factors come into play here, recognizing that this should be done without coercion or inducement, but how do some of these initiatives actually come to play? So autonomy and informed consent, I mean, it's good because it reduces the notion of paternalism, that individuals do have the capacity to make decisions and therefore should be allowed, for lack of a better word, to be autonomous in their decision and make informed consent. Negative because it actually can put difficult decisions in the hands of somebody that may be ill prepared to make them. And when we talk about ill prepared to make them, there's a variety of levels that go along with that. There's the whole notion about capacity, literally if someone has the capacity to make that particular decision. In terms of mental capacity, physical capacity to actually engage into that, but also recognizing that sometimes there's other limits in terms of the types of decisions. So, for example, some of the scenarios in terms of where people might be ill prepared to make the decision because it's a really significant decision, whether or not to participate in another round of chemotherapy. People may be ill-equipped in terms of looking at the other options with regards to if they are being coerced by family members. We've had that discussion in previous tutorials. So what is it that makes people ill-prepared? It could be health literacy levels, truly to be able to understand the consequences. So we really have to look at the notion about, really allowing the person to control what happens to them, and how do we take all these various factors into play. The other thing I'd like to call your attention to is the ethics composite model that's on page 46 of your text. And it does really provide a great way of really looking at decision making and all the different factors that go into that. So I'll call your attention to the model that's on page 46 and really strongly encourage you to look at the part of the readings that starts on page 150 that really kind of walks you through how you can actually utilize this model and what are the various factors that come into play. The other thing I'd like you to think about are our own skills and your own skills with regards to relational ethics. And what are some of the skills and competencies that you need to strengthen to be able to support patients and families in making autonomous choices? Some of those competencies And skills are the notion about just having the information about what are the particular ethical issues they're doing. The competencies and skills about really excellent listening skills. I'll take you back to some conversations in Health and Healing 1 in terms of our motivational interviewing skills, really trying to find out what is truly important to this individual. What is it they're hoping to achieve as we start to go forward? So perhaps also to sit and reflect upon where are your skills in regards to relational ethics. What are the skills and competencies that you have now? And what are the skills and competencies you're going to need to further develop in order to really to support informed decision making and from an autonomous practice? And could it be some of the other things to really to consider, that also people have the right not to choose. And again, we'll bring you back to Aziza's story a little bit later, but people do have the right not to choose, or that people can actually receive too much information, which can be totally overwhelming. So I'll take us back to the conversations that we had in the previous tutorial about, sometimes patient education and the unethical practices. If people can actually receive too much information, does that impede their ability to actually make an autonomous, informed consent and support decision making that really is in their best interest? And the other notion to think about is choice is a value that we need to live, and also recognizing that people can change their mind. A choice is a choice, and it is something that can sometimes be very organic and very fluid based on where individuals are at that particular point in time. There can be situations and scenarios where you have a patient that is about to embark on surgery. They can be literally rolling through the door and can change their mind. And we have to look at in terms of what are some of the factors that enable that, and how do we actually realize and embrace the notion that people have the ability to change their mind, and it's something that is truly a lived experience, and how do we start to address some of those different types of scenarios. Coming back to this model again, it looks at the various components in terms of, again, the notion about consent and autonomy and choice, and that recognizing again that it is my choice to choose, to not choose, or to change my mind. I just wanted to very briefly to bring you back to some of the legislation. Some of this we'll touch upon today, but there's lots of various pieces of legislation that really talk about the issue with regards to informed decision making, who is considered capable of making decisions, and what are some of the different components. And you can see there that the medical assistance in dying, which is Bill C-14, is now part of that legislation that talks about the notion about informed decision making. Autonomy as an entity, it looks at different components here. So autonomy is about having the right and the ability to make meaningful choices. And we'll talk about capacity a little bit later. Again, as I've mentioned before, it is the foundational principle of bioethics, is the notion about autonomy. And there are 4 components, as you can see here, that look at the different aspects with regards to autonomy. So it's about self-determination, which is, again, the individual's ability to choose, to determine what is in their best interest. It is about having freedom to make those choices without coercion. And that coercion can come from, as we discussed earlier, family members, or perhaps unintentional or intentional coercion from healthcare providers. It is about the notion about desire fulfillment, having a goal, but really perhaps not always sure about how it can actually be fulfilled. And the notion about independence, which is, again, highly linked to the capacity and the ability to do things for ourselves. There's also 3 dimensions about informed consent, that it should be voluntary, again, without coercion or inducement. Looking at the ability of the capacity, so the ability of the individual to understand understand the consequences of saying yes, the consequences of saying no, and how capacity can be limited or absent and can change over time. So we've had discussions about this in DOS 1 in terms of the notion about capacity, and how somebody can be fully capable of making a decision, but because of circumstances almost the very next day might be deemed to be incapacitated and therefore not be able to participate that. And the notion of comprehension. This is the actual understanding of the information. So they can lack capacity because of the lack of comprehension, because of language barriers, our own language that we use, or again, the whole notion, perhaps even with regards to about health literacy. The virtues that are inherent when you talk about the notion about informed consent is the notion of honesty, the information that's being presented or perhaps being withheld, the inherent notion about trust, that patients do trust that we do have their best interest at heart, and the notion of power and power differentials. And again, those power differentials can be between the healthcare providers and the patient, or even again, sometimes patient and family members. So again, these are the virtues that are also inherent or subsumed in the notion about what constitutes informed consent. The one thing I think it's really important to talk about is that as nurses, we don't have to approve of a patient's decision. We may disagree with it, but we don't have to necessarily approve of it. And I think sometimes that can actually be really quite liberating. For us as nurses, is recognizing that it really is the patient's choice, regardless of what we think. But even within this decision, if we don't agree, we cannot therefore abandon the patient. And again, we really have to recognize how those power differentials can be unintentionally played out at that point of care in terms of trying to convince the patients what's in their best interest if we don't necessarily agree with what their decisions are. And again, I think the perfect case study was in the readings for this week with regards to Mrs. Winnow and the unbelievable ethical dilemmas that were involved in that case. And that case is actually going to be the basis of your online discussions this week because of the unbelievable complexities with regards to that. But I think, again, a perfect example about how patients' choice can sometimes really conflict with some of those social taboos they spoke about in the article, as well as, again, what we honestly think is in the best interest of the patient. And again, this is where we'll bring in Aziz's case study and looking at, how cultural influences choice. So really looking at it in terms of, again, specifically with that particular case study, she was not about to give consent to that treatment. The notion either about surgery or the notion about birth control without her husband's consent. There was no way she was going to make that decision without her husband. And again, the struggles of the care providers and wondering why she was so adamant that she was not to make that decision. So again, really looking at, how does culture really influences the choices, the choice options, or even someone's ability or willingness to make a choice and a decision on their own. Many, many cultures will defer sometimes to the husband is one example, the oldest male. And again, we have to be respectful, recognizing that that is part of the culture and the rules or the values and the mores within those particular areas. And how does that sometimes really conflict with what we see as independent choice? The notion about assent, which is agreement. So this was referred to in your text as well. The notion about, so even if there's a substitute decision maker involved, the nurse really should still seek the patient's assent. So that's in terms of, are you aware that that's the choice that's being made? We don't make any underlying assumptions if there's a substitute decision maker involved. That we still then ignore the patient. This is the examples that they gave in your text about, where you're dealing more so with children, with sick children. So the example that your text gave is that, if you have a 6-year-old that's refusing chemotherapy, so to speak, but the parent has assented, we still need to look at in terms of, is the child also consenting to the treatment, and then how do we work around some of those nuances versus the example in your text was if you had a 17-year-old, so the parent has signed off on the treatment, but the 17-year-old is now dissenting. We don't disclose, preclude or ignore the dissent from the child. So, really looking at some of those particular areas. The same can also hold true if you have a patient that has some form of dementia, where there may be days where they are not capable of making decisions, but there are days where they may be very lucid and intact. So again, how do we balance this back and forth, but still keeping at center the person, the patient, that it will be that recipient of care. And again, looking at the whole notion about exactly what is informed consent and recognizing this is an ongoing process, that people can consent to something one day and not the next. And there is that constant revalidation that they are fully aware of what that plan of treatment is, what it all entails, and how do we continually engage the patient in that validation process. So again, recognizing sometimes that, as it says here, sometimes providing too much information can almost be seen as being negligent, really actually overwhelming the patient, just as much as providing too little. So how do we making sure that we're continually looking at the opportunities here and looking at how this informs in terms of the overall patient experience? So here's another notion: because no patient can be fully informed, is informed consent actually truly possible? So this is where you get into the legal standard about, what constitutes adequate information, because it is very subjective, and recognizing that, sometimes the inherent situations where people are actually giving consent. They are in vulnerable states, sometimes completely overwhelmed. The language is not something they're familiar with. So from a legal perspective, for the Healthcare Consent Act, it is just the last quote there that what considers adequate information is information that a person in the patient's particular situation would need to know in order to make a decision. So this is where we look at it in terms of how can we at least strive for this, but also validate that they have actually received that information. So how much is adequate? So the information that should be provided is, so what's the problem? The diagnosis, the situation that they're in, the treatment, including what might be some other, so the treatments that's being proposed, as well as other options. The consequences of delaying or not treating, along with the expected benefits and risks of the treatment, the treatment effects, potential side effects, adverse effects, the consequences of no treatment at all. And they're also really quite clear about, when you're having the conversations with the patient, not only documenting that these things were shared with the patient, but they also strongly suggest that you actually also document the questions that were asked by the patient and the responses. So recognizing, again, using our really good interviewing skills and the use of open-ended questions so that we truly elicit from the patient and or their family members what questions do they have, and again, what's the information that's being provided. So again, there's adequate information provided so that it supports their autonomous, informed decision-making. Some of the practical implications for us then as nurses and as healthcare providers is recognizing, the importance of providing individualized care. So recognizing, as we know, no two patients are the same. Their experiences aren't the same. Their lived experience before they even come to us are extremely individualized. So we need to recognize that. Our notions going back to Health and Healing 1 with the conversations with regards to health literacy, making sure that it is our obligation to make sure that the information we're providing is in a way for the patient to understand. And how do we validate that what we have shared with the patient has actually been understood in a way that we need that information to be understood by the patient. So some of the ways that we can do that is, having that patient then reiterate back to us, So what is the treatment? What are the risks? Making sure, looking back again from Health and Healing 1, and the notion about health teaching, that we provide information in a variety of forms. So it's not just explained to them, but some additional written materials that they can have to reflect upon later, opportunities to follow up, to answer any questions they may have at a later time. Giving the patient time to consider those options, not the notion about presenting this, here are your options, and now I need you to sign the consent form. That could actually almost be construed as being coercion. Offering a second opinion, or offering the option of a second opinion where it's appropriate. If there are different options available, blatantly asking the patient, would you like a second opinion? Sometimes patients are very afraid to do that. They feel that it's insulting to the care providers. They worry that the care providers will then be angry. But I think sometimes we need to blatantly say, would you like to have a second opinion on this? And again, the notion about documenting the discussions with the patients with regards to that informed consent. Just a quick overview with regards to the substitute decision maker, and when substitute decision makers come into play. So if the patient is not mentally capable of making the decisions with regards to their care, again, the substitute decision maker will be called into play. It's really important up front to identify with the patient who is their substitute decision maker. So asking, in the event that you are unable to make decisions on your own behalf, who is your substitute decision maker? When we talk about the list in a little bit, we shouldn't just assume that it might be the spouse, because it might very well not be. And we'll talk about that in a second. And then the role of the substitute decision maker is to provide some information and clarification. And again, if they have, especially if they're a specially appointed substitute decision maker, to ask for that kind of documentation. And we'll talk about that in just a sec. So who can be a substitute decision maker? The person, they themselves must be capable to be able to make decisions and understand the information, and again, appreciate the responsibilities that go along with that. They have to be available. So whether that's literally physically available or available by phone, so you need to be able to have access to the individual to make decisions. And they need to be willing to assume the responsibility. And this is another interesting aspect to think about, not only for yourselves, but also for your patients. I'll give you an example of a colleague of mine. So she was she wanted her parents to be her substitute decision maker. And so she was actually having the conversation with her mom. And her mom said, no, I cannot do that role. Because it was along the lines of, this person wanted to be very clear about what her wishes were. She wanted do not resuscitate orders under certain situations, et cetera, et cetera. And her mom said, she goes, I can't do that. She goes, I'm your mom. I love you too much. And I would never be able to fulfill your wishes. She goes, I could never be in a situation where I would need to say, no, end her life, take her off of life support. So again, it's the notion about, the substitute decision makers, need to be able to take on that responsibility and really act in the best wishes or the express wishes of the particular patient in that situation. So here's the ranking, and this is exactly as it's listed in the Substitute Decision Maker Act. So and this is I'll say the highest level, highest to lowest, if you will. So in some situations, there will actually be appointed substitute decision makers. Where somebody has been appointed through even a piece of legislation they are guardians, court appointed guardians, or someone that has actually has the formal documentation that they have power of attorney for personal care. Or they're literally appointed by the Consent and Capacity Review Board as the person's delegated representative. And even in terms of with that power of attorney for personal care, I'll give you an example for both of my parents. Although my brother was listed, had power of attorney in terms of finances, the executor of the estates, et cetera, et cetera. I was power of attorney for personal care. So I had the ability to make decisions with regards to the care needs, whereas my brother was there to look at the finances, the estates, et cetera, et cetera. Beyond that, in terms of individuals that are almost like formally appointed, this is the statutory substitute decision maker list. So the spouse or partner, common law partner, same-sex partner, whoever is that person is designated. It could actually be a parent or a child. When they talk about the notion of about age limit, usually typically the substitute decision maker needs to be at the minimum of 16 years of age. The only time that rule goes by the wayside, if you will, is if you have a situation where it's the parent of a child is 16 years of age or less. So you could have a parent, a very young parent. So you can have a child that's in your care that needs decision maker, but the parent is actually 16 years of age. That parent makes the decision. Siblings or any other relative. So that person identifies. So that's why, again, it's really, really important that you actually ask, who do you want to make decisions on your behalf? Because you could have a situation where someone may have a spouse, but they're estranged from one another. And they don't want that spouse making decisions. They prefer to have a friend, who else that they've designated. So again, it's really important that we clearly identify who is their substitute decision maker and make sure that is formally documented. What do? They can consent or refuse treatment. They literally make the decisions on behalf of the individual. They're involved in the decision about the treatment plan and what's involved with regards to that. The expectation is that they should be abiding by the express wishes of the patient. And again, this is why it's always really important for individuals to articulate what their expressed wishes are. The notion is that they are deciding what's in the best interest of the patient, considering, again, the patient's values, beliefs, and current wishes. And there are always situations sometimes where we may disagree again, but again, it is the notion about that the substitute decision makers, again, that's why you really want to be clear that, that they know what the wishes are and they are willing to follow through on those. Some of the 4 factors that take into consideration with regards to treatment is the treatment likely to improve the condition or overall well-being or prevent further deterioration? Does the condition or well-being is likely to improve, remain the same? Does the potential benefit to treatment outweigh any risks? And is there any type of less restrictive or intrusive treatment available? So these are some of the factors that should come into play when we're asking people to make decisions. The last thing I want to talk about today is the notion about medical assistance in dying, as it's still relatively new. It just was proclaimed, Bill C-14, in June of 2016. So what medical assistance in dying basically is these 2 factors here. It is the administration by a medical professional or nurse practitioner of a substance to a person at their request that causes their death, or the prescribing or providing by a medical professional or nurse practitioner of a substance to a person at their request so that they may self-administer, and in doing so, causing their death. So where, again, the notion about medical assistance in dying came into play was really through great, I'll say, public opinion and public pressure from individuals that were really quite felt that they wanted to be able to choose how to end their life. So you recall earlier cases of the Sue Rodriguez case, because of the fact that currently under the criminal code, it is against the law to assist someone to commit suicide. So that's where the whole notion about where it was against the law, because it was under the criminal code, that it is against the law for anyone to assist someone to commit suicide. So what medical assistance in dying did through great public pressure actually resulted in a change to the criminal code. that removes this restriction, if you will, to only medical practitioners and nurse practitioners. So physicians and nurse practitioners only. And we'll talk about what that looks like in the next coming slides. So it was really about people wanting to have the ability to make that choice, to not have to die in pain, to not have to worry about what their last days would be like, and recognizing the importance about wanting to make that independent choice and having that option available to them. There's three main stages in the medical assistance in dying, and the College of Nurses guideline walks you through again what are all the various components that have to go into that. You have to determine what the eligibility is. We'll look at that in a second. Ensuring safeguards are met in terms of documentation of the conversations, truly assessment of the person's capacity, and then looking at how they actually provide some of the various stages of assistance. So I'll refer you back to the College of Nurses guideline because it does walk you through all the various components and the expectations, primarily with regards to the nurse practitioner. But as registered nurses, we still need to know what those safeguards are, because it is also our obligation to making sure in terms of our advocacy role for the patient that all those various safeguards are exactly in place. This is the eligibility, which is still up for a bit of debate, to be perfectly honest. And I think we're starting to see some changes in this particular area. So first of all, the person has to be a minimum age of 18. And I will tell you that in itself is a bit of debate. People feel that it's almost unethical to not have children, or the option available for children or people under the age of 18. But again, you can imagine all the nuances involved in that, but that's still a point of contention, if you will. They have to be capable of making decisions regarding their health care, so the notion about capacity. They have to have what's referred to as a grievous and you know the word, medical condition. So something that is really quite palliative, terminal. There's no chance for any type of improvement. It has to be voluntarily requested. And this is a huge important point. Because although there was changes to the criminal code, what we cannot do, we cannot counsel. So patients must initiate the request. They have to request information about medical assistance dying. They must initiate the conversation. So although the criminal code's been changed to eliminate the legal penalty, if you will, for physicians and nurse practitioners to offer medical assistance in dying, it's still part of the criminal code to counsel. So to actually, I don't want to use the words encourage, but to suggest it to individuals. So to counsel is still against the law. So that's why it has to be voluntarily requested by the patient, not by their family, not by, a substitute decision maker is not part of this because, again, it has to be voluntarily requested by the patient. The patient must be able to give informed consent. This is another little, I'll say, bit of a bone of contention. They have to be able to give informed consent right up until that very last second. Before the physician or the nurse practitioner actually provides that medication, or right up until the physician or nurse practitioner actually hands them that medication that they then self-administer. So this has been a bit of a bone of contention for individuals that have, let's say, ALS, so amyotrophic lateral sclerosis. So by the sheer nature of their disease, they might not be able to provide informed consent. So that in itself has also been a bit of an issue with regards to debate. And they actually have to be eligible to receive health services funded by the government of Canada. So what that criteria has been put into place is to avoid the notion of medical tourism. So people actually coming to Canada to receive medical assistance in dying and then leaving, which is actually almost the direct opposite, because before medical assistance in dying was in place, people were actually going over to Switzerland and Sweden to actually receive this option because it wasn't available to Canadians here. So that's the eligibility. The other this component in terms of the grievous and irrevocable medical condition, it has to be that the criteria for that also includes the notion about intolerable suffering. So where this has also created great debate is that individuals with mental illnesses are not deemed eligible for medical assistance in dying, and this is another point of debate. So right now it's primarily focused on physical conditions, but not mental conditions. So for some individuals whose mental condition, they feel that it's irremediable and it causes intolerable suffering. Again, that's a point of debate right now in terms of opening that up as potential criteria. So here's the role of the nurse. And again, I will refer you back to the college guidelines in terms of specifically. Registered nurses and registered practical nurses can participate in providing nursing care and then aiding either the NP or the physician in medical assistance in dying in accordance with the law. So that might be, again, starting the IV. It might be providing psychosocial emotional support. So we can actually participate in the procedure in terms of what is the other nursing care that actually is involved. I'll really reinforce as nurses, we can provide information about medical assistance in dying only after the patient, again, has requested it and they've actually had that initial conversation with their nurse practitioner or their primary care provider. So if they have questions about what's the next step, I think we need to be able to be informed to talk about, so what is the due process here, and provide information and education to the patients. But again, we cannot counsel. We cannot suggest it. So if a patient were to ask you about, does this facility provide medical assistance in dying, or what do you think about medical assistance in dying? Again, it's about, asking them, why are they asking you the questions? What is their interest? What questions do they might have? And then immediately referring them on to their nurse practitioner or their family care provider. The other role we have is still providing excellent nursing care. This is end of life care. So we would still provide excellent physical care, psychosocial, emotional, and spiritual care, not only to the patient, but to their family members as well. So it is still part about providing really holistic care for the patients and their family. There is the notion, though, about conscientious objection. So for some individuals, because of their personal beliefs, religious beliefs, cultural beliefs, this is not something that they just cannot participate in terms of that actual, I'll say, final act of the individual being given the substance that actually ends their life. So nurses can conscientiously object. You need then to really inform your employer, so to speak, that it really is just about transferring the care. It's about really changing your assignment. If you honestly cannot provide care to that patient, then it's just about changing the assignment to another healthcare professional. What the college guidelines is very clear about, though, that you are not to convey to the client that you disagree, that you think it's wrong, so intentionally or unintentionally. So no personal moral judgments about the beliefs should be expressed. So again, it's your opinion, that's your right, but that is not to be conveyed to the patient, because again, that could also almost be seen as a form of coercion. Some of the aspects with regards to ethics, that there's been some discussions with regards to, what does this do for the nurse-client relationship? The notion about advocacy and trust. The notion about social justice, access to medical assistance in dying. Even from a physician perspective, if a patient or a nurse practitioner, both, requests of their primary care provider medical assistance in dying, and that nurse practitioner or physician just does not believe in it, doesn't agree with it, they are obligated to refer that patient to someone that does. So they can't say, sorry, we don't do that here. I don't do that. They are obligated to simply refer them on to someone else that does. The other aspect that really called into play, the notion about medical assistance in dying and the issue about social justice, where a lot of people had really quite I'll say difficulties with this, because the other side of the coin was, well, we wouldn't need medical assistance in dying if we had adequate access to palliative care services, which we don't, to be perfectly honest. We don't do a good job with palliative care. So the notion about, well, we still need to talk about palliative care, because that is still a huge component in terms of end-of-life care. For us as nurses, sometimes being caught in the middle, organizational hierarchies, professional hierarchies. As registered nurses, we don't have a direct role in this, but these are still the patients that we provide care for, day in and day out. And recognizing our professional responsibility in terms of end-of-life care. What are our competencies that are required in terms of communicating with the patients, our knowledge with regards to medical assistance in dying and the various steps and the procedures that need to be in play, and how this really interacts with our overall scope of practice. I know from speaking with lots of colleagues, this is different. Medical assistance in dying is actually quite different. As healthcare providers and as nurses, we see people's lives end many times throughout our career, whether it's through somebody arrests, and we are unable to bring them back to life. We have expected deaths sometimes in terms of palliative care. But I will tell you for healthcare providers, because it's relatively new, it's some individuals have a little hard time with this, knowing that, let's say as an example, that in that room down the hall right now, this thing is going down. And some people really embrace it and rejoice in the fact that patients have that opportunity. Others really find it a little weird, to be perfectly honest. So I think we really have to recognize that what is our response to this, and how am I feeling about this, and what is my personal versus professional obligations with regards to this. There have been lots of opportunities within our particular LHIN here where the medical assistance in dying has provided in many opportunities, whether it's in a hospital or in the community. And for individuals that have had a chance to participate in it, they really feel that it is really unbelievably empowering for the patient. There's been examples where patients that have had their own wakes, but they've actually been there. So they get to say their goodbyes. They get to have the party, if you will. People get to say to them their own goodbyes. So it is a different aspect. But I think we really have to look at how do we really embrace this as a new option, but not losing sight of the other needs in terms of end-of-life care and going and so on and so forth. The last thing to take, right back from where we started from is that the whole notion about informed decision making is, again, we still cannot lose sight of those power differentials between ourselves and our patients, and making sure that our own beliefs and values about what's important, what's good, don't act as a power differential that actually has a negative influence on the decision making and the autonomous rights, if you will, of the patients in our care. So I hope you found this helpful, and I look forward to your discussions in the forums this week.